Thank you so much. Hello, everyone. Welcome to today's webinar series. We are so glad that you are here. As I mentioned earlier, if you haven't already done so, please take a moment to drop in the chat your name, affiliation, and where you are joining us from today, so we can get a sense of who is in the room. My name is Kristen Mallory, and I am here with my fellow co-chair, Dr. Adugna Yiman, and from the Systems for Health Working Group. And we want to thank you for joining us for this webinar series. Before we jump into our agenda for today, I wanted to give a quick plug about our working group if you have not already heard or are not already a member. So this is one of the technical working groups as part of the core group. We are the Systems for Health group, and here's just a little description. We're a group of people who care about and are seeking to promote people-centered, community-inclusive systems for health. So there's lots of pieces within that. Some of the key cross-cutting issues that this group has explored is the full integration of community-based systems into national health systems and strategies, community health, human resources, work on community health workers, community management structures, social capital, civil society engagement, and social accountability to support health systems responsiveness. If you are not already a member of the working group or on our listserv, please let us know. The listserv email is below. We'd love to stay connected with you after this series as well. And thanks to all of the members on the working group that are here today. Our agenda for this session is first to have a brief context on fragility and the context globally. Then we will introduce our speakers, and we will hear a case study from Somalia along with South Sudan, and then have some time at the end for some discussions and questions. So with that, I will pass the virtual microphone to my fellow co-chair, Adugna.
Thank you, Kristen. So my name is Adunya Imam. I serve as a senior technical advisor for Action Against Hunger based in Washington, D.C. To set the stage, we'll first present a global perspective on the status of health and health systems in fragile context before diving into specific country examples. But first, what is fragility? According to the Organization for Economic Cooperation and Development, OECD, fragility is the combination of exposure to risk and insufficient coping capacities of the state, system, and/or communities to manage, absorb, or mitigate those risks. And according to their 2025 report, about 2.1 billion people, which is 25% of the world population, lives in contexts of high and extreme fragility. Next slide. We know that people living in fragile states face a devastating and disproportionate health crisis. Their average life expectancy is 7 years shorter than in other developing countries. The situation for children and mothers is even worse. Although fragile contexts are home to only about a quarter of the world's infants, they account for nearly half of all global deaths under age of 5. The child mortality rate is almost 3 times higher than non-fragile countries. And for mothers, 95% of all preventable maternal deaths occur in these low-income and fragile settings. The average maternal mortality ratio is more than double the global average. In extreme cases like South Sudan, it goes as high as 1,223 deaths per 100,000 live births. Next slide. This crisis is compounded by a collapse in public health services and a crashing cycle of poverty. Fragile states are epicenters for epidemics, accounting more than 70% of the global cases of diseases like cholera, measles, yellow fever and what you have. And then vaccination programs have failed, leaving like half of the world's zero-dose children. Health emergency is intertwined with poverty. By 2030, it's projected that up to 80% of the world's extreme poor will live in these regions. Next slide. Furthermore, conflict has driven rates of anxiety, depression, post-traumatic syndromes to be 2 to 3 times higher than in other populations. And at the heart of this problem is a complete health system failure. These systems suffer from total lack of resources, including a workforce crisis due to brain drain, infrastructure that's often deliberately destroyed, and failed supply chains. The collapse of health governance and data means these states have no ability to respond to shocks, trapping populations in a cycle of disease, poverty, and instability. With this background, our two experts will now share experiences from Somalia and South Sudan, detailing how fragile health systems overcome barriers to deliver services to populations in need. Thank you.
Thank you so much, Abuna. Great context setting. It is an important issue and a lot of interconnections with the health system. So it is my pleasure this morning, afternoon, or evening, depending on where you are calling in from, to introduce you to our esteemed presenters this morning. First, I'd like to introduce you to Dr. Mohammed Sheikh Omar. Dr. Omar has over 10 years of experience in health and nutrition service delivery. He holds degrees in medicine and public health and currently serves as head of the Health and Nutrition Department for ACF Somalia. He has led major donor-funded projects, strengthened health systems, and directed emergency responses, including COVID-19 vaccination and the 2022 drought crisis. Next, I'd like to introduce you to Dr. Camden Hoffman. Dr. Hoffman brings more than 20 years of experience advancing public health globally. She holds a PhD in behavioral and community health science, 2 master's degrees in international development and global public health promotion, and a bachelor's degree in biology and environmental sciences. She currently serves as the technical director for social and behavioral science at Chorus International and has guided national strategies and large-scale investments worldwide. I could say much more about both of our presenters today, but to keep things moving, I would love for you to hear directly from them. So I will pass the microphone to Dr. Mohammed.
Thank you so much, Christine. Hope I am audible.
You are.
Yes, good morning and afternoon, everyone. It's a pleasure to be here to share ACF experience in strengthening health systems in fragile and humanitarian systems, drawing specifically from our work in Somalia. Today, our discussions will walk through the context, the key challenges, how ACF has worked with the Ministry of Health and also partners to address those challenges, and finally, areas that require future collaborative efforts. In the context, if you can go to the slide on the context. So Somalia remains one of the most fragile and food insecure nations globally, as per the EU Informed DAX and Global Hungry Index. Cyclic droughts and floods and disease outbreaks, as you can see from the trend analysis, have eroded community resilience. In the humanitarian response plan, recording 6 million people are in need of humanitarian assistance, nearly 1 in 4 Somalis, and with projections of around 1.85 million children to be projected as acute malnutrition, which is an alarming of 150,000 increase from early 2025. And this has actually exacerbated by the USAID cuts in 2025. In 2023, actually, USAID was the second largest recipient in Somalia. Around 44% of the national response were coming from the USAID. So you can imagine withdrawing all that support and how a fragile system like Somalia will deteriorate. In terms of access to the essential package of health services, 41% of the total population have an access, and 60% of the health services is delivered by the private sector, with 19% public facilities fully functional. In terms of human resource density, it is 1 per 1,000, which is below the WHO threshold. And in Banadir region, actually in Mogadishu, is one of the rapidly urbanizing cities in Somalia, with also will further strain the already fragile system. In the next slide, I will take you through an overview of the ACF Somalia work. ACF is a part of a global network operating in 55 countries. Somalia managed through the US headquarters in Somalia. We have been present for over 32 years, implementing programs across 10 regions in integrated approach of health, nutrition, wash, food security, livelihood, emergency response, and protection. Our work strongly emphasizes localization, partnering with 6 national organizations that implement 18% of our annual budget. Currently, we are implementing a Federal Ministry of Health flagship initiative funded by the World Bank called Damal Afimat in 2 regions, Bay and Bakol, which we have seen a lot of improvements in terms of the health system strengthening. As one of the pioneers of the health system strengthening in Somalia, ACF has transitioned all the staff at the field level to the Ministry of Health since 2019 and currently support around more than 2,400 staff in 112 facilities, accounting 23% coverage of the public health facilities in Somalia. Through our participations in consortiums and working with partners, we have reached more than 3 million in 2024. In the next slide, I will be talking about challenges to provide quality services. Delivering quality healthcare in a fragile setting like Somalia, it's an uphill task. Challenges range from inadequate human resources, weak governance systems, supply chain disruptions, access constraints because of security and also distance, disease outbreaks including cholera, measles, and recently diphtheria outbreak, cultural barriers to data limitation, and infrastructure gaps for dignified health services. But these are not impossible. With strong partnerships and health system strengthening approach, meaningful progress is possible, and we have seen it so far. In the next slide, I will be talking about how did we overcome these challenges. At Action Against Hunger, we have strategically shifted from operating ACF private facilities to working through the government and public health facilities, ensuring sustainability as well as national ownership, and as a part of our health system strengthening approach. Our programs are fully aligned with the government policies and frameworks, including the essential package of health services. ACF in 2019 supported actually operationalization of the district health management teams using the WHO guidelines, and developed TORs and also job descriptions and to strengthen government ownership and stewardship at the district level through these engagements with the local governance structures, while maintaining a balanced approach that combines humanitarian life-saving interventions with the long-term resilience programming to build stronger, more sustainable health systems. In the next slide, we will see how we overcame some of the challenges using the health system building blocks. For example, in terms of HR for health, which was a core success for us in Somalia at ACF, we had actually in 2019, when we were transitioning from ACF contracted staff to seconded staff, we had developed a memorandum of understanding with the Ministry of Health, and we clearly defined roles in the recruitment and the management of staff. ACF handles job descriptions, payrolls, salary payments using government scales as per the EPHS, while the Ministry of Health oversees advertisement, shortlisting, and performance management. ACF also influences intentional inclusion for people living with disability and monitoring at the HR level. For example, in one of the projects funded by FCDO, we had a total of 88 staff, frontline staff. 11 of them are from minority groups and 3 are people living with disabilities. And not only at this, but we also monitor at the service delivery level. ACF also operationalized the district health management teams in 2019 from and influenced also peer agencies in the same consortiums to support the government developing job descriptions, terms of reference, providing training on governance, leadership, HR management, and data quality. Joint supportive supervisions using digital tools now helps both ACF and MOH teams to track performance and accountability. Furthermore, community engagement and quality review meetings, quarterly review meetings with ministry, consortium partners, donors ensure that services are responsive to the community needs. And as you can see from the photos of training district health management teams, as well as joint recruitments with the Ministry of Health. In the next slide, we'll talk about the health system strength, health information systems. Data is the foundation of good decision making, especially in fragile contexts with limited resources like Somalia. ACF has adopted the government tools such as the HMIS reporting tools at the facility level and also reporting to the DHIS2, working closely with the Ministry of Health to close data gaps, particularly around inclusion and active monitoring for people living with disability and minority groups. In 2025, 7% of our total reach so far from the people of minorities and people living with disabilities, as well as conducting data quality audits, as you can see from the charts. We have seconded to enhance this, the data management officers in 23 districts, significantly improving data flow from the facility level to the national quality and use at the local and national levels. Additionally, we have piloted digitalized data systems across 43 facilities with an aim of transitioning from manual registers and cards to digitalized systems with ongoing discussions for national adoption and interoperability with other systems, including DHIS2. The digitalized data system have an appointment reminder through SMS as well as audio SMS for ANC and immunization. This shift actually is to the real-time digital data have significantly strengthened accountability and evidence-based decision-making. In the next slide, we'll talk about access to the essential medicine and technologies. We have invested heavily in improving access to essential medicine and equipment through robust procurement systems and supply chain. ACF in Somalia is one of the largest in terms of supply management after the UN, and we have ensured consistent availability of these commodities through engagement with the foundations. Because of the accountability measures, we have adopted the pharmaceutical information management system, a digital system adopted from IMC through one of our consortia called Afimat Plus, and all our supply chains is digitalized to the last mile tracking, enabling efficient redistribution. In one of the projects, we were able to redistribute 1.1 million worth supplies and as you can see also from the photos, we also also partner with WFB Logistic Cluster to airlift supplies to remote locations, as well as linkage with communities on transporting supplies using community networks in access-constrained locations, demonstrating the power of collaboration and partnership in health system strengthening. In the next slide, I will talk about infrastructure improvements, and infrastructure is central to the service quality and dignity. Together with the government and partners, we have constructed and rehabilitated 29 health facilities representing 27 facilities. Facilities are now inclusive of people living with of persons with disabilities, with ramps and accessible latrines. We have also piloted, because of the climatic crisis in Somalia, climate proving in 7 facilities, and also integrating WASH in nearly 80% of the health and nutrition sites, which enabled better outcomes for nutrition caseloads and also for the SRH beneficiaries. Improved infrastructure has reduced travel distance in remote locations thanks to the investments from the World Bank. For example, in Qura Jome, the nearest hospital is 90 kilometers away. And because ACF have invested a lot when it comes to the infrastructure now, there's enhanced staff retention in hard-to-reach locations like Qura Jome, which hosts also minority communities. You can see also in before and after photos of a pharmacy unit, and you can see the transformation moving from under-equipped structures to modern, dignified pharmacy unit in health facilities ready to serve the beneficiaries. In the next slide, I will talk about emergency response. As we focus on the health system strengthening, we also build the emergency. We respond to emergencies, and the health system strengthening is a foundation, as you can see, from different range, from disease outbreaks, a climatic El Nino flood response, as well as clan conflict responses, which ACF has responded. And with these emergency responses, we partnered with DRC also to pilot an initiative called Integrated First Line Response, which now is adopted at national scale. In the next slide, we will talk about areas requiring additional efforts. Despite the progress made, there are key areas needing continued attention, like expanding the health workforce, specifically in remote areas, strengthening infrastructure and financing mechanisms, enhancing also domestic investments and also fundraising so that government accountability, as well as to ensure sustainability, and building resilience to climatic and epidemic shocks through preparedness and surveillance systems. From the next slide, we'll talk about how ACF is layering on integration, photos from the field, focusing at community level in terms of preventive activities at the facility level while waiting for services, health and nutrition mobile teams in hard-to-reach locations like Hudur, integrating WASH interventions for holistic approach, and later as a graduation model linking with our FSL teams to distribute solar irrigation Bawat systems, as well as training farmers to address nutrition causes at the root causes. Next slide, we'll see about how communities are working in conflict zone, like in Seoul region. You can see from the left side of the photos, a community rehabilitated health facility completely, and currently they support the running facilities for electricity and water through community networks, and also linkage with the diaspora on providing equipment. And on the right side, you will see ACF's investments in one of the hospitals on infrastructure with the Ministry of Health in inaugurating the opening of the facility. In the next photo, you will see how ACF is delivering an integrated emergency responses at community level with outreach providing immunization services, disease outbreaks for cholera management, working with donors like ECHO to transport supplies to hard-to-reach locations, and also handovering supplies to the Ministry of Health, and onboarding ambulances to enhance referral linkages. from the community to the facility level. And next, you will see investments in climate proving as well as IPC. And lastly, I want also, finally, none of this progress would have been possible with our donors and partners, particularly ECHO, World Bank, FCDO, IOM, TF GAG, and a few others, as well as our implementing partners. Their support continues to make tangible differences in strengthening Somalia health system and improving lives. To conclude, Somalia experience to demonstrates that health systems strengthening is possible even in the most fragile context when efforts are locally led, evidence-driven, and partnership-oriented. Thank you so much. Back to you, Christine.
Wow, Dr. Mohammed, so much great information for all of us to digest. If you do have questions or reactions to this particular presentation, please put those in the chat. We will continue with the next presentation and then open up for dialogue on both. But so you don't forget your questions and reactions, feel free to put them in the chat now. And with that, I will pass to Dr. Hoffman for our next case study. Thanks, Camden.
Thank you, Kristen, and thank you, Dr. Mohammed. That was fabulous. So I'm going to give an overview, slightly different than Dr. Mohammed, more high level on the social accountability approach from Chorus International that was implemented through the Momentum Integrated Health Resilience Project that was previously funded by the United States Agency for International Development. The project was terminated, but it is now reinstated to provide life-saving interventions in the former countries, including nutrition, integrated community case management, newborn resuscitation, maternal child health care, water and sanitation and hygiene, among other life-saving interventions. Next slide. Before I get into the detail of this approach, I'm going to give you a quick overview of Chorus International. We're a family of 5 organizations that started from World War II and 1960, looking at Lutheran World Relief, which is our rural economies, agriculture and livelihood and climate arm, IMA World Health, which is our health arm, Ground Up Investing, which is our impact investing arm, Charlie Goldsmith Associates, which is our digital management information systems arm. And from our impact investing, we also have a farmers market coffee with coffee brands in Uganda. And I'll be following up this holiday season for those of you that would like to purchase for your family and donate to children and mothers in need worldwide. So the rationale for the social accountability approach that Chorus is taking is looking especially at fragile settings where representation from marginalized groups is limited, which results in limited ability to respond and be responsive, and also can create inefficiencies in the community and health systems. Participation by communities can be very low. Some community members have never heard their voices at all heard in a public setting, and sometimes feel that that's normal, that they're not supposed to have a voice. There is also a need to establish a better dialogue between health providers and community members, where there is a lot of mistrust in the health system, especially in cases of fragility. Next slide. So social accountability goes by many names, and I'm glad to see many of my social accountability colleagues online, as well as colleagues from South Sudan. So the approach that typically is coined by this phrase is looking at the collective action between community members who are demanding something from either service providers or others that provide a service. In this case, we are focusing on the shortcomings in health services, as Momentum Integrated Health Resilience was focused on service delivery, demand creation, access to quality health services. It's deeply rooted in a participatory approach with governance at that center, and having service providers, health providers, responsive to community demands, hoping to improve practices to advance health service delivery. Next slide. So this is a PACT infographic. It is the theory of change that was developed in the Momentum Integrated Health Resilience Social Accountability Strategy. If anyone would like that strategy, I have a soft copy that I can share after, and it's also in I believe it's in our Social Accountability Repository from the core group, which was developed several years ago. But what this theory of change is trying to explain is that communities will be empowered and participate through amplified voices and have neutral, safe spaces for dialogue and advocacy. Providers ultimately will have the capacity to respond to communities' concerns, and there will be effective interactions between communities and providers, enabling an open space for communities and providers to take collective action. And so hopefully, if this happens, the resource flows to health services will improve, increased responsiveness from the health providers, increased knowledge among communities to understand what is available at the health services, and improved attitudes. And at the outcome level, looking at increased access and utilization of health services, improved quality of care, strengthened health governance, and ultimately increased health resilience to respond to shocks and stresses and maintain continuity of care in these types of fragile settings. Next slide. So there are several models that Momentum Integrated Health Resilience considered. One developed by Save the Children is Partnership Defined Quality, which works to improve the quality and accessibility of services while having the community and providers drive that quality improvement process. And there's typically 4 or 5 steps, basic planning and design, building support and sensitization in the community, exploring quality between communities and health workers separately, and then bringing them together to do what we call bridging the gap. And then that results in a prioritization of issues that are important to both the community level and the providers. And then an action plan, working in partnership together, allows for both the communities and the providers to move forward with low effort and high effort, meaning low hanging fruit and ones that require more resources moving forward to improve quality health services. It does link quality assessment and community mobilization, and it requires a commitment from key members of the community and the service delivery system in what we call quality improvement teams, or QITs, which are the backbone of the PDQ action planning process. Next slide. The other model that we utilized was the community scorecard, which is more, I would say, community driven in the sense that you do develop a community scorecard with indicators that are jointly brought together by the providers and the community. It has a similar flow in terms of the different steps. The bridging the gap is called an inception phase, where the same process happens, where community members and service providers come together and review those issues that drive user satisfaction with health services. It's measured by the indicators, and it can vary on how often that measurement takes place. But it's a good way to get direct feedback from communities in terms of, is the action plan that comes out of the community scorecard achieving the indicators and perceived outcomes that were envisioned by this process. Next slide. So in terms of the criteria for choosing approaches, definitely in consultation with country stakeholders, the ability to work with government health providers is essential in fragile settings, looking at the power dynamics and the wider context involvement of marginalized and vulnerable groups. And there's a really delicate balance given trust issues and previous war and conflict between the health providers and community members. Next slide. So this is an example of an action plan that came out of Magui County in South Sudan, and you'll see that some of these issues are really are easily solvable by the community and health providers, while others are more challenging. So cleaning up the health facility, or in the case of the Adus Bridge, building a human bridge to get supplies across during flood seasons and what have you. And you'll see that there's the contributing factors, solutions, actions, roles and responsibilities, and a timeline. What is missing here is the budget, but we did have a budget with this as well, some of which was in kind from the community, and some of which was part of the project and the government. Next slide. So something very unique to the fragile settings in South Sudan, we did as a project a social norms assessment, and what we found is there's deeply entrenched social and cultural norms that underlie all social accountability approaches, activities that we did. What we decided as a team with the communities and stakeholders is to include a community action cycle, which was modified from Georgetown Institute for Reproductive Health and Save the Children, originally focused on youth, to bubble up and discuss issues of gender, gender-based violence, etc. And the idea behind this was to have a group, a community action group formed in the community that would focus on issues of gender and gender norms, which were extremely important, as I mentioned, from the social norms assessment. And then that would be it brought together in a synergy meeting with the quality improvement team of PDQ. Given that there are providers and community members in the quality improvement team, issues of gender were actually brought to the QIT and discussed at the facility level. So it was a great model to learn from, taking research to practice from our social norms assessment. Next slide. So some examples from the community action cycle action plan. We saw that there was a lack of parental support for girls in seeking health services and information. Most men need their women or partners to seek consent before accessing health services. Religious beliefs had an impact on decision making, sex differences, and domestic work, not giving women time to seek services. These are things that were addressed through the action planning. Next slide. So some lessons learned from adapting in South Sudan, and these pictures were taken by my colleagues in South Sudan on the MER project in Magui. And they need to be, the activities need to be well coordinated with other community-based activities and be complementary. Adaptive management and learning is key in terms of pivoting, especially in shocks and stresses. Local power dynamics, as I mentioned earlier, including political and economic factors, are critical to consider in these situations. Political support, governance, and leadership are key for sustainable approaches in social accountability. Next slide. So again, some other adaptations. Confidence building meetings with community reference groups, including youth and women groups, helped foster equitable shifts in power dynamics. We spent more days in that bridging the gap so that we could build a rapport, a stronger rapport, and dive deeper into quality issues and behavioral issues. Just like we call in the United States a parking lot, I asked my colleague, what do we do if we run into an issue that is heated in our bridging the gap? And my colleague said, well, we can dance, we can sing traditional songs, tell stories to really lighten the heat in the room during those sessions so that everybody feels comfortable again. Looking at a balance on the quality improvement teams with a lot of community participation and leadership and decisions on health matters. The community action cycle helped to complement the partnership defined quality to address those deeply entrenched social norms, sex issues, and dynamics at the community levels. Next slide. This really excites me to see that some of the process outcomes, we were using most significant change and getting a lot more community-driven outcomes. However, due to the termination, we weren't able to explore that more. But suffice to say, we still saw some great results. Participants were able to identify and discuss and analyze problems at different levels, and realizing that community resources could be used in kind to build and address some of the issues. For example, some people with disabilities were concerned that they couldn't access the health facilities. So the community got together and built a ramp out of wood from community resources so that people with disabilities could access those health facilities. That shift in understanding resource mobilization was really key in being able to see how some of these approaches could be more sustainable without additional funding. And as we're seeing in the current environment, funding is limited, so being able to be resourceful and look within is very important. You'll see a couple slides here, a couple quotes here, my apologies, from the Boma chief in Magui County and a health provider in Magui County who came to the realization that this process did allow citizens and community members to voice their concerns about health services and enable agency among health providers to be more supportive in decision making for their clients and patients. Next slide. So the takeaways really gives communities agency through their amplified voices to make change. Community resource mapping and mobilization of those resources can improve quality. There was an improved sense of ownership of the health system. The client-provider interaction also was greatly improved. Communities felt they had more agency in terms of the participation and open processes, and the data for decision making was really helpful, especially in collaboration with communities who face those day-to-day challenges in those fragile settings. Next slide. There's just a couple of pictures on the right. That man in the straw hat was very active in the Bridging the Gap sessions and was invited to this radio talk show in Magui County, as well as you'll see on the left, youth were referred to counseling sessions as a result of the community action groups. Next slide. And I'll wrap up there with a lovely young adolescent woman meeting with a female health provider in one of the clinics. And I just love the smiles on their faces. Over to you, Kristen and Adugna.
Thank you so much, Camden, for another very rich presentation with lots to think about. Before we transition to the next piece of the webinar, which will be time for questions, I'd like everyone to take a second. I just dropped in the chat a Mentimeter link. If you can click that link, and it'll give you 3 spaces to write 3 words or phrases of just general takeaways after hearing those 2 rich presentations. So let's just take a minute to click on that link. I will share the screen so we can see our growing collective insights as we've listened to these presentations together. while we heard about some different contexts, maybe even different types of interventions, what are some of the things that you could see across the presentations? Seeing commitment, continuous communication, adaptation, shared responsibility, resourcefulness, responsive, life-saving, thoughtfulness, sensitivity, improvement, holistic thinking, advocacy, success. Excellent. Well, if you haven't yet added to the cloud, please do so, and we can share the cloud after the presentation. So looking at the time, we've got about 10 minutes for some questions and answers with our presenters. I'm going to look in the chat. If you could drop your questions in the chat, we will see if we can answer some of them within the 10 minutes and also make a commitment to follow up via email if we're not able to get to all of them. Maybe as people are thinking about their questions, we can start with kind of a general question for both presenters. Both of you talked about kind of the importance of agility, adaptive management in this kind of ever-evolving space. I think this past year, there's just been many more kind of new evolutions of the sector, of fragility, any kind of recommendations or thoughts for the group around how the work that you shared can help us think about this sort of new chapter and how we can support communities and countries in health system strengthening.
Sure, I can kick it off, Kristen. So we're having a lot of internal discussions at Chorus as the landscape is shifting more responsibility to communities and government stakeholders, and we're shifting to more of a social impact, social enterprise organization to really understand the needs of clients as opposed to a donor-focused model. And I think when it comes to social accountability, some of the outcomes that we enjoy seeing from social accountability, especially some of the social and behavior changes, we're also realizing that internally and on a global scale, that perhaps some of the language that we do use now may not be as understandable to others. And so we're exploring both internally and globally with partners such as the Global Alliance for SBC and the Africa Society for SBC. What does social and behavior change, social accountability, what do those look like, and how do we do a better job explaining those? For example, does social and behavior change, can we say that we're promoting healthy practices and really move that towards language that people may understand a little better, while keeping the fidelity of the models here? So whether social accountability is improving responsiveness or what have you, it's just thinking about the process is the same, and we've said this a lot in SBC. Some people still call it information, education, and communication. If you're following the process and doing the formative work and the pre-testing and the implementation and monitoring, if you're following all the processes, some of the language may be able to be refreshed and finessed so that we have a better buy-in globally from the community. I think also some of the resilience mapping and stakeholder mapping that we undertook under Momentum helped lead to more sustainable approaches in terms of working with local women's groups, youth groups, etc. So I'll pause there and see if Dr. Mohammed has anything to add.
Thank you. Thank you so much. So in addition to that, actually in Somalia, we have seen a lot of changes when it comes to the shifting landscape in terms of the humanitarian settings. But again, we have also seen some opportunities and communities coming forward. Like, for example, in Lasanod Boame, we have seen communities supporting infrastructure improvements and also communities also fundraising to sustain the health facilities as well as equipments and also linkage with the diaspora. So as the global landscape is changing when it comes to the resources for the humanitarian settings, like for example, in fragile settings, we have these opportunities at community level and linkage with the diaspora community as well as with the government, just to have like advocacy on domestic resources for health and also using the declarations and also the national strategies within the country, like the health system strategic sector HSS3 and also the national transformation plan within Somalia to just use that as an advocacy tools to enrich this. And actually, with the communities, we are seeing a lot of dynamics shifting, not only in the health, but also in the broader sector. And we are seeing actually with communities that we are currently working and the initiative called Humanitarian Access Initiative with the University of Sussex, like communities are supporting us to transport supplies on road because of access constraints. And that actually is becoming a lot of cost effective when it comes to the resources and the use of resources optimally, and also the power of partnerships, because we are not working in silos. Although we are in a fragile settings, we have a lot of opportunities and also synergies with other actions, like example, working with the logistic cluster, with other developmental actors, the resilience programs, so that to maximize impact. So as the resources is shrinking again, we have some opportunities to capitalize on so that we don't lose the gains that we have made in the humanitarian sector. Back to you, Christine.
Excellent. Well, thank you both for those responses. Any questions from our audience or anything you'd like to hear more about from the presenters?
I have seen one question
Okay.
related to Somalia on diphtheria case outbreak, as well as how do we manage. So ideally, we have currently some outbreak in Somalia, mainly related to disease outbreaks like measles and diphtheria. A majority of the cases are aged kind of over 5. 76% are over 5 cases with no history of vaccination. And majorly, actually, it's across the country. And one of the things that that Somalia as a country is doing is weekly disease surveillance to understand the magnitude and also the hotspots to provide responses. And from the data we were seeing at national level from the first week to the 43 week epidemiological week, there's a decline right now in the cases of the diphtheria. In terms of responses, actually, there's a coordination and leadership chaired by the Ministry of Health at the national level, case management and infection prevention control at the respective hotspots. In actually, we support 112 facilities in Somalia, and in those facilities, we are also providing case management, not only us, but again, all other partners, the weekly disease surveillance and reporting using the electronic version of in terms of reporting, and also doing laboratory confirmations, and then also enhancing vaccinations. So what is happening in areas of the hotspots, we have had a coping strategies from these outbreaks. One of it is like there were a lot of missed opportunities at the health facility level. children were coming for a screening, either for nutrition services or for curative services, but they were missing some immunization services. So we restructured the patient flow in the health facilities to avoid children who are zero dose. And what we are seeing here is like once you finish the screening, the first point of contact will be at vaccination room, where you will be assessed for the vaccination. Then you will go to either nutrition or health services. And that actually we are identifying a lot of cases at the facility level. At the national level, WHO, UNICEF, and the Ministry of Health and big consortia are doing big catch-up campaigns just to do mass vaccination campaigns for Benta as well as other antigens, and for children under 5 providing TT. And then there was a press release actually from WHO and UNICEF in Somalia stating 70% of the children are fully vaccinated across all key vaccines. And once we reach more than 75%, I think we will reach the herd immunity, and then these cycles of transmissions will be reduced.
Wow. Excellent. Thank you so much. And thank you for that question. Looking at the time, any last kind of takeaways or things for us to be aware of as we move forward with this type of work from either of our presenters or both? Be a couple last words. You're on mute, Dr. Mohammed.
Yes, I think one of the things I would say is the power of partnerships. Because from a fragile system, a country like Somalia, we have seen the power of partnerships, working with local agencies, sister agencies, the government, and putting the government at the stewardship driving seat actually can help a lot when it comes to building systems as well as sustainability. So that's what I could add.
Excellent. Camden?
I think you said it well, and Dr. Mohammed, I salute you for living and working in such difficult environments, and you're constantly smiling and doing great work. So thank you for your work and your dedication.
Thank you so much to both of you for being here today to share your experiences, to highlight all of the resilience and best practice that's happening in really difficult circumstances. I think it's motivating and hopeful for all of us to hear about and learn. We are at the hour, so I want to thank everyone for being here with us. Again, big thank you to both of our presenters. This is part of a quarterly webinar series. So if you like today's conversation, we hope you'll join us for another one in the future. If you have ideas on different topics or things you would like to showcase through a forum like this, please reach out to us. We'd love to collaborate with you. So with that, I hope everyone has a lovely rest of their week, and hopefully we will be in touch. Take care, everyone.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.
you.
Bye-bye.
Bye. Thanks a lot, Kristen and Camden and Mohammed.
Good to see you, Laurie. Thanks for
Yeah.
coming.
Great.